NACRT followed by esophagectomy complication rate. So we've also had our fair share of complications. So the overall is about 50%, major complications about 25%. And that's the breakdown of complications. So if you look at the major complications, our nerve palsy is about 9%, anastomotic leaks about 10%, 2% chylothorax, bleeding about 3%, and the other rarer complications. So I'll start with anastomotic leaks. The anastomotic leak is one of the dreaded complications after an esophagectomy, even in the best of the hands. And the rates of anastomotic leak is anywhere between 3 to 15% reported. Now, we need to actually firstly define what is anastomotic leak. Basically, it is defined as a full thickness defect, which involves either the esophagus or the anastomosis or the staple line or the conduit. And it is classified as 3 types. Type 1 is the leaks which are just radiological. Clinically, the patient is fine, therefore does not require any medical or any special or dietary modification. So that is a type 1. Type 2 is leaks that require some form of intervention, but not surgical therapy. It does not require a reoperation. And type 3 leaks are leaks that require a surgical intervention. So these are the more serious leaks that require intervention. So this is the, again, the ECCG classification of the types of leaks. Now, do we need to do a routine postoperative contrast study? We actually did a randomized controlled trial, and basically we found that, and again in the literature also, says that it is not necessary to routinely do a contrast study post-esophagectomy. You need a high index of suspicion. And if you suspect that clinically that the patient has got a leak, then based on that, you can do a study rather than doing the study for everyone. And what study do you do depends on the level of suspicion. You can swallow, or you can even do a contrast CT scan, which will not only tell a leak, but also tell if there is any associated sepsis and collections. And of course, an early upper GI endoscopy by a senior person with minimal insufflation is probably maybe necessary, particularly when you are looking at more serious problems, conduit necrosis. So I'll just briefly describe a little bit about what the literature says about the factors which affect the management. Firstly, the site of anastomosis, where the anastomosis is a very major factor. Is it in the neck? Is it in the thorax? Because it can, it will determine how you manage this. Another factor which affects the management is the viability. You need to make sure that the conduit is viable, because if you have a conduit that is not viable, then it can be a major disaster, and that needs to be picked up quite early. So your index of suspicion should be high. You need to know, it also depends on the time of the leak, how the ultimate results will be. Whether the leak is contained or not, whether there is systemic sepsis, how healthy the patient is, and whether they are nutritionally depleted as well. So these are the factors, main factors, which affect the outcome of the anastomotic leak. And if you look at the general principles of how you manage it, it's like any other esophageal perforation. So firstly, you need to be able to somehow seal, or at least it may not be a watertight seal, but at least prevent further contamination. So whatever it takes to prevent further contamination, you need to do. Secondly, you need to drain the sepsis effectively. If there is a collection, it needs to be drained. And third, and perhaps sometimes forgotten, but it's a very important thing, is the nutrition of the patient, because without adequate nutrition, the patient is not going to be, and you already know that these patients may have neoadjuvant chemotherapy or chemoradiotherapy, and already they are nutritionally depleted in the preoperative period in some way or the other. And the operation is a major insult for them. An esophagectomy is a major insult, and therefore it is very, very crucial to take care of the nutrition. So these are the three basic principles that you need to somehow do. And if you look at what can be done in order to seal the perforation, the more minimally invasive or less invasive way is by putting a stent. Okay, so instead of open surgery, now that's become the procedure of choice. And in order to drain the sepsis, many times you'll be able to do this
You're forcing yourself.
through minimally invasive or
Don't study for it. Immediately shut your book.
I think. Can you please mute your mics because it's a bit disturbing. So to drain the sepsis, you can do it minimally invasive way. All right. So these are the two things that you generally do. So in order to seal the perforation as minimally invasive as possible, nowadays it's a stent. And to drain the sepsis, you can do this radiologically. And of course, do not forget nutrition. Now, to classify leaks, they classified as early or fulminant leaks. So these are leaks that present very early, less than 48 hours. And usually these are like a major problem such as a conduit necrosis. And of course, you have a cervical leak, a thoracic leak, which can either be contained or uncontained. If you look at early fulminant leak, these can be quite morbid. Conduit necrosis is a major problem, so you need to pick up early. So in a post-operative patient who becomes sick, they may manifest these very subtle signs. Maybe they may go into atrial fibrillation, they may go into arrhythmia. So you need to be able to pick up this early. That is crucial in salvaging the patient. And it usually means a technical problem. So they can present with sepsis, they can present with shock, and there may or may not be anything in the chest drain. And to manage early fulminant leak, such as a conduit necrosis, basically you need to act aggressively. So a high index of suspicion, appropriate investigations, including an upper GI endoscope to look for the mucosal viability, and then you probably need to do something surgical. Here, you may not be able to manage this minimally invasive or by putting a stent. So these are instances where you need to make a decision and go in early to do something. And that something might be actually taking down the conduit and giving a cervical esophagostomy. And that may be the only thing that may salvage the patient. This was one of our patients, basically quite a few years back. And you can see that there is some necrosis here, some ischemia in the conduit. And this had to be, we had to go back in and take this down. And you can see that this is not going to get better with conservative management, whatever you do. And this is another instance where there is conduit necrosis in the neck. So that is the more serious part of it. Now, if you look at cervical leaks, generally cervical leaks are benign. And that's one of the advantages of having the anastomosis in the neck. So if you have an anastomosis in the neck, generally it manifests as a wound infection, maybe a bit of surgical emphysema in the neck. And all it may require is just to open the neck incision. You may have to debride the wound and maybe pack the wound. Need to go to theater, but still it is not a major operation. And if by doing that, you can actually make sure that the conduit is viable in the neck. This maybe have to be treated with antibiotics and maybe enteral nutrition till the leak heals. Of course, this can lead on to post-operative strictures and things, but those are the late problems that are associated with a neck leak. but certainly the morbidity is much lesser if the anastomosis in the neck. But not always does cervical anastomosis just present in the neck. For example, we had this patient who was all right, who had a McEwen's esophagectomy, who was all right till about the sixth postoperative day. Suddenly he became quite unwell in the ward, so he had to be shifted to the intensive care unit. And he was then imaged, and he actually became quite sick and acidotic, had to be intubated, and that was a CT scan, which showed significant sepsis in the right chest. So what had actually happened is, although the anastomosis was done in the neck, the remnant esophagus was probably a bit long, and therefore it slipped down into the mediastinum, and whatever leak had happened was happening in the right chest. So just beware that even if you do a neck anastomosis, this doesn't always necessarily have to present in the neck. It can actually present as a chest leak, particularly if your remnant esophagus is a little bit long. So this is what we had to do. So we had to take him back to theater. He had quite gross sepsis in the right chest cavity. So this all had to be washed out. So this cannot be managed just with a chest drain. So you can see there is quite gross contamination, has to be debrided. And because this patient had a thoracoscopic operation to start with, we were able to do this through minimally invasive technique. And at the same time, once this was done, we put a stent intraoperatively. So basically, did this first. So basically, we put a stent into the esophagus, and this was a removable stent, and then turned them and did the thoracoscopic washout. So the moral of the story is basically a neck anastomosis can sometimes present as a chest leak. So be careful. So the next one is a thoracic anastomosis. Thoracic anastomosis can be contained. So if it is a small perforation or a small leak, it can be well contained, and this can be quite easily managed radiologically. So if it is a contained leak, all it needs is probably appropriate drainage and, if necessary, an esophageal stent. Whereas if it is uncontrolled, like the previous patient that we were discussing, it may need thoracoscopy, decortication, and stenting. Now, this has actually revolutionized how we are managing esophageal perforations and leaks. We have a variety of covered stents available. The indications are basically you need a stable patient. You can't do this on an unstable patient. You need to be sure that there is no necrosis of the conduit. So if there is ischemia of the conduit, the stent is not going to work. And it also depends on how big the perforation is. It has to be less than half the circumference. If it's a very large perforation or if it's completely off-ended, then putting a stent can be difficult and may not be appropriate. Okay, and also you need to put the right size stent so that there is no leak around the stent, because if it continues to leak around the stent, then it is not going to help. It's got a reasonable success rate of 70 to 80%. However, because these stents tend to migrate, and in spite of fixing these stents by clips, etc., you may need to re-intervene in these stents. So it may not be just a one-off procedure. You may have to put the stent. Sometimes these stents may slip down. Sometimes these stents may migrate, and therefore you may need to reposition or put another stent. Generally, these removable stents, covered stents, you can leave for about 6 to 8 weeks. Beyond that, if it still needs to be there, then they may have to be replaced. So you can't do this for all places. It's not suitable for a very high cervical anastomosis, because if it's too high, if it is near the cricopharynx, then the patient may not tolerate a stent. They may cough. or if it's a or if it's a leak spanning the G junction, or if it is into the, basically, if it is in the esophagus, it is easy, it stays there. Whereas these kind of stents, where it is into the stomach, or if it is in the into a sleeve of the stomach, then they can migrate. Uh, and during this, once you put a stent, don't assume that everything is going to be normal. So you need to be actively looking for worsening sepsis, because many times these stents don't work, or they may actually be still ongoing leak. So if it doesn't work, then be prepared to do something more aggressive, like an operative intervention. Uh, Another modality which has come now is a VAC. So basically, it's a sponge which has got a tube, and this is suitable when when there is a cavity associated with a leak. So basically, assume that you've got a leak and there is a cavity in the mediastinum. So even if you put a stent, that cavity is still going to be not addressed. So this is a suitable way of doing it. It's not freely available. So we actually had a patient. So this is a total gastrectomy who had a leak, and you can see that that is the cavity. That's the anastomosis, and that is the cavity, sorry, the leak, and then the cavity, anastomotic dehiscence, and then there was a large cavity in the mediastinum. So we actually prepared something like this ourselves. And this has had, you can't just put it in blindly, you need to put it in with an endoscope and connect it to a suction, like a vac suction. So we were able to manage this patient. Obviously, every time you change this, you can't leave it for too long. This needs to be changed every 2 or 3 days. So every time you change it, it needs an endoscope. But it is a reasonable way of managing cavities associated with it, which cannot be drained. Suppose this cavity can be drained with a pigtail or a radiological drainage, then you don't need to do this. But if you got a cavity which is not accessible radiologically, then this is a good way of dealing with the cavity. Of course, when you have this, you can't put a stent. So obviously, this is an alternative for a stent. And once the cavity becomes smaller, then you can put the covered stent. So basically, for leaks, you need to have a high index of suspicion. You need to pick them up early. You don't need to do routine contrast study, but have a high index of suspicion. For fulminant leaks, such as conduit necrosis, early surgery. For non-fulminant leaks, non-operative but aggressive management. This will involve either a drain placement plus or minus stenting. And if things don't improve, then you need to be prepared to do surgical treatment. So that is about anastomotic leaks. Doctor, can I just go through till the end and then for questions?
Yeah, sure. But only thing, Indian, today we have to hand over by 7 because Pradeep Rebela is coming from Hyderabad to call Dr. Sis. So you can stop 15 minutes before.
I'll stop whenever. You can stop me whenever you want me to stop. I'll stop.
15 minutes before and we'll open for discussion.
Okay, sure.
I think this session will require 2 hours easily.
Okay, sir. So this one, the next one is bleeding. Bleeding basically can happen both minimally invasive, open. This is the Oringa series. Basically, very impressive results, 1% major bleeding. And if you look at the minimally invasive technique, this is a Lukitic group where they've reported about 0.6% who had major bleeds during surgery. So this is a patient that we had. This was a mid-third tumor. This is post NACRT. So you can see that there was a it's sort of quite adherent in the region of the thing. So we were slowly dissecting and then managed to hit this bleeding point. So this was probably the tumor getting attached. So what started as a small ooze then slowly became quite significant. So by this time, we were thinking, we were getting ready to convert this into open surgery because it was quite friable tissue, and there was no way we were able to get something to clip or to suture. Was very difficult. So all that we could do was try to pack it, and even packing was quite. Initially, it was still continuing to bleed. So quite a scary situation. I think by this point in time, we had lost about half a liter of blood. So we were almost ready. We got it was informed the anesthetist, and we were ready to open. Um, and slowly, in about, let's say, 10 minutes time, it slowly with pressure, things seem to settle down a bit. And then basically this was once it settled down, then I was able to go onto the other side, onto the aortic side. There was a it was stuck on, and there was a vessel coming from the aorta directly. So going a little bit more posteriorly, we were able to then identify the feeding vessel. And once that was done, then this bleeding here thankfully stopped. So I just put this on because basically bleeding intraoperatively can be quite scary, can be quite daunting. But I think with reasonable, you need to be calm, you need to be composed, and most of the time you will be able to control it, but be prepared to open if necessary. This was another instance where I had another major bleed. This was just at the point of entry. So this patient, again, neoadjuvant chemo RT, had a lot. The lung was stuck to the chest wall, and on entry itself, I think I made the injury into the lung parenchyma, and because the lung was stuck, I just did not have any space to operate on this patient, and you can see that that's the lung parenchymal injury that was causing it. Luckily, because this was only a venous injury, slowly this stopped with a little bit of pressure, and then we were able to continue this. But these are things that can happen in laparoscopic surgery. If you look at open surgery, particularly transhiatal esophagectomies, you need to look for certain red flags. Basically, bulky tumors. Need to be careful when there is a loss of plane with the aorta and the tracheobronchial tree or the pulmonary vessels. Corrosive injuries, as Dr. Chandramohan was alluding to during his lecture, can be quite difficult. So you probably better to leave the esophagus in situ and then do a colonic bypass. Or if patient with achalasia having a previous myotomy where things can be stuck to the previous myotomy site. So all these are probably red flags when you try to do them through transhiatal surgery. But the single most important contraindication to proceeding with a transhiatal dissection is the surgeon's assessment of the esophageal mobility. So when you're dissecting it, keep an eye on the monitor. So when you're doing a transhiatal dissection, your eye needs to be on the monitor. And how to get out if there is bleeding when you do an open esophagectomy. You can put the patient in Trendelenburg position. Good exposure, illumination is important as with any bleeding. Avoid blind application of vascular clamps. And the magic thing is to pack. Okay, you need to quickly be able to pack. Now, when you're doing a transhiatal esophagectomy, there are three scenarios. One is you can get dark venous blood from the hiatus or from the cervical wound. The second scenario is if you get bright red arterial bleed from the hiatus. And the third scenario is there is no bleeding anywhere, but the patient goes into severe hypotension. So these are the three possible scenarios. And the first one is a venous bleed. Okay, so dark venous blood, usually from the esophagus vein when you're doing a transhiatal dissection. The second, when there is arterial blood, means that you've injured one of the major, one of the aortic branches. Even it may be a small aortic branch from the to the esophagus, but it can be bleed quite profusely. And the third scenario is when there is no blood, but then the patient goes into hypotension, means that the patient is bleeding into the chest cavity probably, and you need to quickly put in bilateral chest drains. So these are the three things that, so when you have bleeding, so just be mindful that there can be three scenarios. The most common is, of course, the venous bleeding. So if you have dark venous blood, you need to ask, is the esophagus mobilized or removed? If you're almost towards the end of it, quickly mobilize and remove the esophagus and pack. So basically what you should be able to do is pack the chest cavity with the neck already open. You can pack from the top, pack from the bottom as well. And that should control the bleeding. Now, if you need to open and if things are not controlled, after some time you remove the pack, you then think that this patient needs a thoracotomy. Then while you're there, you can try to position with the help of the anesthetist, the tube, because this is a single lumen tube, mind you, because it's a transhiatal esophagectomy. So you try to get the tube into the left bronchus and then turn the patient. Now, which side you do the thoracotomy depends upon the level of the esophagus till where it is dissected and the possible vessel. Okay, so if it is up to the mid or upper esophagus, and if you're suspecting a zygous vein, then you do a right thoracotomy. If you think the bleeding is much more lower down, and if you think it's from the aorta, then it may be preferable to do a left thoracotomy. Now, this I'm showing this with permission from Dr. Chandramohan. So this was a transhiatal esophagectomy, and you can see how dramatic this bleeding can be. It's just like opening a tap and everything. But obviously, this can be controlled, and this was controlled in this patient with appropriate packing. And as you can see here, when things are under a little bit more control with a clamp, this was bleeding from the azygous vein and the superior vena cava, which need to be sutured. So again, you need to be aware that you need to be able to deal with the situation. So to conclude the bleeding part, major bleeds are relatively rare, thankfully. Can be avoided by careful preoperative planning, and patient selection is crucial with meticulous operative technique. And when they do occur, you need to have a methodical response. So you don't panic. You need to have some sort of a backup plan in your mind right when you start, particularly when you're starting a difficult case. Keep things ready. If you're doing it thoracoscopically, keep a open set ready in the operating theater, and don't hesitate to call for help if necessary. The third thing that I'm going to discuss today is a chyle leak. Chyle leak is a rare but life-threatening complication, and the incidence can be anywhere up to 4%. It does have a mortality rate as well, because this, although it is not as dramatic as bleeding or an anastomotic leak, this can nutritionally deplete the patient and then can lead to a mortality of up to 30%. Now, if you look at the normal anatomy when you do a thoracoscopic operation, the thoracic duct lies between the azygous vein and the aorta. So this is almost the location where you can constantly see it. You don't see it as a duct. Usually it will be covered by a layer of fat, but that's a normal location where you would normally find the thoracic duct. Now, of course, like anything else, there are anatomical variations, and the normal anatomy is only found in 50%. When I say normal anatomy, the complete course being normal is only found in about 50%. So you can have so many variations in the thoracic duct, just like your bile duct anatomy. So it can be duplicated. So basically, this is because embryologically, the thoracic duct starts on both sides. So it's a bilateral structure, and then one side atrophies, and then it sort of forms, it takes the course that we normally study in the anatomy textbooks. But then because it is a bilateral structure to start with, you can have all these variants of anatomy with the thoracic duct. Now, coming to the mechanism of injury, you can have a complete transection. You can have a lateral branch damage or a laceration, or there can be a variant anatomy. Now, question number 1, do you need to prophylactically ligate the thoracic duct when you do an esophagectomy each and every time? Now, there are multiple studies which have been done, but there is actually a randomized control trial which has been reported with a large number of patients, and it showed a significant advantage of for post-operative leak. So basically, if you routinely ligate these ducts, obviously the incidence of post-operative leak is going to be lesser for your patients. However, if you ligate these thoracic duct in each and every case, does that need to lead on to nutritional problems? Because basically, thoracic duct is a structure which transports nutrition, the lipids. Does it lead to immunological effects? So can you just blindly ligate it in each and every case? Does it lead to retroperitoneal fluid retention in the postoperative phase? So all these questions, we don't know the answer. It doesn't cause any major problems, we know. We have no idea. Probably it does cause some nutritional and immunological defect in the short term, very short term, but it is not. It doesn't cause any clinically relevant major side effects if you do it. So, in other words, it is okay to ligate it every time if you think it is necessary to do it. So this is one of our cases. Basically, what we do is because we operate after chemoradiotherapy, many times things can be quite hostile in the chest. So if things are friendly enough and if we find the planes, then we go ahead and ligate this and remove the thoracic duct along with the lymph nodes in every case. But this may not be possible in every case, particularly after radiation. So if it is very hostile and if it looks like things are very stuck, then we are not able to do it all the time. So in other words, if it is possible to do it, like you can see that there is a good plane between the aorta and the thoracic duct, and it was removed incomplete along with the fat and the fibrofatty tissue till the hiatus lower down, and the entire thing was removed. So this, if possible, we do it all the time, but it may not be possible all the time, particularly because we are giving radiation for all our patients. This is another patient. This patient incidentally had a small aortic aneurysm as well, which made it difficult. So anyway, this patient did not have radiation. So you can see that the planes are beautiful. And that's the azygous vein. And once this is done, you can see that that's the thoracic duct there. Okay, so the thoracic duct was seen, and we had then gone down and ligated the thoracic duct. But in the process, basically, that's the recurrent laryngeal nerve on the aorta. So basically, it was a good dissection, but in the process of it, we saw another structure here, which looked like a lymphatic duct. So we thought it might be an aberrant there, just below the azygous vein there. So we thought we'll clip that. So that is being clipped. Maybe we should have just left it alone. So that's another clip going there. It looked all right now, but then somebody decides to put the third clip, and then it starts to, that's probably damaged it somewhere. So anyway, so this subsequently needed suturing. And anyway, then we went down and also ligated the thoracic duct below. So I just showed this to show that you need to be, if you're not excising the thoracic duct, ligating the thoracic duct or excising it in every case, be mindful of a small leak that can happen. And if you can suture this like this so that it doesn't cause any problem in the postoperative phase. Now, do you need to, for oncological reasons, do you need to always remove the thoracic duct? We know that if you remove the thoracic duct, which is here, you will be able to remove more lymph nodes which lie along the thoracic duct. So this has been shown in various studies, but if you can see in this study, again, the recurrent laryngeal nodes, the esophageal nodes, again, significant number difference when the thoracic duct is preserved versus when the thoracic duct is excised. So if you excise the thoracic duct, if it is possible, obviously your lymph node count will increase, but does it translate to survival advantage? Doesn't look like it. So basically, as I told you, in our practice, we try to remove it if possible, but we're also mindful of the fact that this may not actually translate into a major survival advantage, as we know from the literature. Now, what do you do? So this is all intro-op. So what do you do when you have a postoperative chylothorax? Essentially, you need to be aware. So basically, it will start when the patient is not eating. The patient, you will have a large amount of clear fluid in the chest drain. Okay, and once the patient is started on jejunostomy feeds or starts orally, then it will turn into milky white. So if you see that, then obviously you know what the problem is. Keep the patient nil per oral. You can start them on medium chain triglycerides. So this is already this gets directly absorbed into the portal system. So this does not go into the thoracic duct. So medium chain triglycerides can be given for nutritional purposes. Start them on TPN if necessary. Octreotide sometimes helps. And then when do you intervene? So if the output is more than a liter, then it means that you need to go in. If the output is less than a liter, then you try all your conservative management. The maximum that you can go is about 1 week. And if still at the end of 1 week, it's more than 200 ml, then you need to look at doing something surgical, because you can't leave it to drag on, because if you leave it too long, then the patient becomes nutritionally compromised and you can't do anything. So just a few clips. This was a patient who he not had an esophagectomy, had a radical neck dissection and had a thoracic duct leak in the root of the neck. And basically they could not identify the thoracic duct when they re-explored him in the neck. So we then went in thoracoscopically, and at the region of the hiatus, we were able to clip the duct. The next patient, this was a patient, this was operated by our thoracic surgeons, had an open thoracotomy for, I think it was a PDA ligation. So had a thoracic surgery and had damage to the thoracic duct. So this again, because had an open the thoracotomy in the first place, it was difficult to do this by thoracoscopy, but anyway, with a lot of perseverance, we were able to then ligate the thoracic duct in its usual location. And this is one of our own patients who had a esophagectomy and then developed, this was a thoracoscopic McEwan's operation, and had a thoracic duct leak. So we had to go back in. So I think we went in about a week later. And she had a collection, a loculated collection. And I'll just fast forward this video for so this was actually the place. So in fact, during the operation, there was a suspicion, and the surgeon had put a clip and taken a suture, but obviously that was not enough. And the patient was having the leak from the same point. So when we went in, we knew where to go. So we went in around the same place, and it was indeed leaking from there. And then we had to dissect it more aggressively, and then it was almost like taking a mass suture ligation in the region of the hiatus, which we did, and the patient settled down. So to conclude this part, it's a rare complication. There's some more, I think. So this is chylous ascites following esophagectomy. So chylous leak need not be necessarily in the chest. Sometimes you can get it in the abdomen. This was one of our patients. who had esophagectomy, and then I think we had injured the thoracic duct in the region of the hiatus, and basically had a chylous ascites like this. And this one, we we approached our radiologists for interventional radiologists, and what they did was they injected some lipiodol into a groin lymph node, and you can see the lipiodol coming up. It's going into the retroperitoneal lymphatics, and this itself, the lipiodol itself, is a sclerosing agent, and this can sclerose the retroperitoneal lymphatics. And this patient actually settled with just this intervention, but eventually this will go into the cisterna chyli, and you can actually then radiologically inject lipiodol into the cisterna chyli to stop the leak. But in this patient, basically just the lipiodol into the retroperitoneal lymphatics stop the leak. So basically, to conclude, it's a potentially preventable problem. Routine ligation of the thoracic duct may decrease the incidence. And for oncological reasons, there is no long-term advantage, but if you're doing it routinely, then it is okay. You need to have for post-operative control, you need to have a high index of suspicion post-operatively. The key is when to intervene. Early surgical intervention basically gives good outcomes, and you can do this through minimally invasive procedure. And mind you, there are radiological procedures, interventional radiological procedures, which are promising. Thank you. I think I finished on time. I've got
Thanks. And you have 15 minutes. First, we'll ask comments from Dr. Chandramohan. Then I request Chandramohan to unmute himself and comment if he's there.
Radha, I have unmuted already. Are you able to hear me?
Yes, sir.
Yeah, I've taken very sincere notes from you, Inian, so I can give few valid points. We have extensively covered leak, wonderful. And there are two things I want to tell now, which you have not covered, which will be very, very vital for the young.
Yeah. Yes, sir.
The airway injury, rather you give another opportunity for him to talk about the airway injury, because
yeah, fine.
You have enough.
1 hour is too short time. Yeah.
No.
Yes, sir. Yeah.
Yes, sir. We'll have one more session. Well, we'll continue and you'll follow up. Yeah.
Because there are both the leak as well as the chyle leak gives enough time for you to even take advice from others. Whereas the airway injury, you have to tell them the tips and tricks, because they are in the scene. They don't have much time to save the patient.
Sure.
And the next important thing when you survive this is the conduit necrosis. One point alone I wanted to add for that was the conduit which you showed also. Whatever we want to do is, if it is only the tip necrosis, we need not to remove the entire stomach. The rule which I follow is, if the stomach below the level of the suprasternal notch looks fine, we need not to remove the conduit. We can still take a chance. And the nutrition which you stressed was very, very important. All our patients, we do a feeding jejunostomy. So the feeding is started on day 1 so that you can maintain the nutrition. And you stress nicely on the point of stent, which is very difficult in the neck, and it is not necessary also. And before that, neck leaks, just open it and leave if it is not a conduit necrosis. The only thing which can happen is only stricture. Invariably, it will be dilatable stricture. And bleed is major thing which you have covered everything. If there is any specifics I can answer, I don't want to intrude into the wonderful lecture.
No, sir. No, it's not intrusion. It's actually.
The session is open for others to question now. Please unmute yourself one by one. Identify yourself and ask your questions, because we have 12 more minutes before you go to the next.
Things I will tell Radha. One, I have another session on the conduit necrosis, which will be the most difficult thing to manage.
Okay. Dr. Swapnil, to start with, I'll choose the person. Dr. Swapnil, what is that you want to ask? Dr. Farhana Zabin.
Sir, wonderful lecture, sir. Thank you, sir. Sir, I want to ask one question, sir. You mentioned about for fulminant leak, we have to intervene with the early surgery. With non-fulminant leak delayed, we can watch, observe. How can we find it is in fulminant leak, sir? Condylar necrosis, clinically, how can we find, sir? Both of them will have tachycardia, sepsis, etc. No, sir. Please explain, sir. Thank you.
I think it's a good question. That early endoscopy helps because if you suspect that this patient has become very sick, then the only way that you can diagnose, obviously you can, the imaging will not show the necrosis, and of course your inflammatory markers, other things, they just only help. So it's clinical suspicion and an early endoscopy. I think that is crucial. So if you think that there is it is a problem, I think it's better to do an early endoscopy. If you have a neck anastomosis, it's always easy to open a few sutures and have a look at the conduit in the neck. So if you have a neck anastomosis, but of course the most crucial thing would be an early endoscopy, I think.
Yeah, Kislai, what is that you want to ask?
Yes, sir. Good evening, sir. Sir, my two questions. One is, if there is a partial conduit necrosis, where do we leave the distal end?
Okay. So as Dr. Chandramohan was saying, basically, if it's only a very small amount in the tip, then that's fine. You just leave it in situ. But you need to take it back into the abdomen. So you need to resect and put it back into the abdomen. And then essentially you will have to go back in much later. Obviously, the patient will have a feeding jejunostomy and then decide. You will not be able to use the same conduit most of the time. You will have to use probably colon, but at least there is some somewhere, the length where you can anastomose is there. So basically, you leave it into the abdomen, back into the abdomen after resection appropriately, and then you just have to come back on a later date to join it back.
Okay.
Dr. Chandramohan, is that right, sir?
Can I add a point to that, Radha?
Yeah, yes.
Yeah, we have made the mistake of removing the stomach, thinking that it is a total conduit necrosis. Once you do that, if you see only a small segment of stomach is gone, what you can do is you can keep the stomach tube in the subcutaneous plane. It will come as far high up to the suprasana notch also. And you have enough time because of the feeding jejunostomy. You can always do a delayed reconstruction. If it was not a tubularized stomach, you have the option of even tubularizing now and doing an anastomosis later. But as Inian pointed out, the best option if you have retrieved the stomach is to go with a coloplasty later.
Thank you, sir.
Okay, sir. Sir, my another question is regarding, is there any, regarding chyle leak, is there any way that we can intraoperatively find where is the chyle leaking? And because many times we go and see we cannot identify the duct, we cannot identify where is the leak. So ultimately we end up doing mass ligation. And how to do mass ligation? We have to dissect between aorta and azygos, and then tips regarding in that scenario, sir.
Okay. So if you're going in after the esophagectomy, then obviously you can give certain things. What was traditionally described was Baker's green. That's basically fat. Anything that contains fat, some cream is all right. You can give it at least 3 or 4 hours before, and when you go in, this is for re-exploration I'm talking about. So when you're re-exploring it, so that you can identify the location of the leak, because by that time it would have come there. If the patient has a feeding jejunostomy, which the patient will have after the operation, you can give the cream through the feeding jejunostomy about 4 to 6 hours before, and that can help you to identify the leak. As far the second part of the question, obviously it is if you're doing it by open method, it's a mass ligature right at the hiatus, at the you feel the aorta, put your hand on it, and then take a a mass ligature just beyond the aorta, all the structures that is there. And that should hopefully include the thoracic duct. If you're doing it thoracoscopically, I guess you have the advantage of magnified vision, and it's almost, in that region, it's almost fairly constant. So you can go between the azygous vein and the aorta in that planes. It may be a little bit deeper, but generally about 4 or 5 centimeters above the hiatus. If it is clean, you can dissect in that plane, and invariably you will find the thoracic duct there, and you can clip it. All it needs is a couple of clips, and that should sort out the problem.
Dr. Prasanna?
Sir, if we are ligating thoracic duct and at a lower end and excising it, what is the proximal, cranial end to ligate it?
So it depends on where you actually visualize it. So basically, it will be above the azygous vein, and usually that's where it sort of goes underneath and it crosses over to the other side. So sometimes it can be on the right side, right up to the root of the neck. So basically, when you're doing your dissection, you will be able to decide where. But it doesn't really matter. Basically, what really matters is your bottom clip. If you've identified it and clipped it, if you're going to do an on-block dissection, so you stay along the plane of the aorta and go as far up as possible. Usually, it will be above the azygous vein, that level. It will cross over and it will disappear. So at that point, you put a clip and remove it. You can even not clip the top end because there may not be a major leak. The most important clip is the bottom clip.
So if there are no more questions, thank you everyone. Thank you so much. And I shall.
Hello.
Meeting.
Hello. Sir, one question, sir. Sir, a few points about the post-operative conduit dilatation, sir. Post-operative conduit dilatation.
Okay. Sorry. You're asking about post-operative conduit dilatation.
Yes, sir.
Okay. So basically, if you have a redundant stomach in the chest, this can be a problem. Usually, this can manifest as in many ways. Usually, it's not an early problem. It's a problem much later. There's also a side question to this. Do you do a pyloroplasty or a pyloromyotomy all the time? So that is again one of the things that will influence whether there is going to be a problem with your conduit, because and of course the hiatus, is it going to be tight or not? So all these factors will influence. Usually it's a late problem. You need to image it, and if it is a significant problem, then you may need to go. You can go through the abdomen most of the time. If you will be able to sort it out through the abdomen, you don't need to go into the chest for this problem, I think.
Thank you so much, Dr. Inian, for much effort. I will not leave you. We have to come back some other time. And
okay. Tomorrow, the next few days, I won't be able to come. But anyway, sir,
when you're free, let me know. Then we'll get back to you. And in the meantime, I have to go to Hyderabad to listen to the choledochal cyst by Pradeep Premala. Thank you so much. Thanks.
Thank you, sir. Thank you, Dr.
Sir.
Thank you. Thank you. Thanks, everyone.